Hello everyone, this is a video, it's a series called Your Question, My Answer. So in this, one of the follower, Chuck asked me this question. And this is about the video I have on TikTok about NSAIDs and its a long-term effect on your kidney and heart and etc. etc. So he says, just curious about what you might think of this strategy. Take 2 ordinary aspirin tablets, 325 milligram, once every 7 to 10 days. This acetylates the serine residue in cyclooxygenase more or less permanently, thus making that particular site ineffective for making prostaglandin. During the interim time between aspirin doses, take acetaminophen for pain as recommended. What a smart question. I mean, this is somebody who knows chemistry very well. And I think it's a very thoughtful question, Chuck, and I appreciate your thinking mechanistically. You are correct that aspirin irreversibly acetylates cyclooxygenase called COX, especially COX-1 in the platelets, which is why even low dose of aspirin has a lasting antiplatelet effect about 7 to 10 days, which is a lifespan of a platelet. However, there are a few important clinical considerations I wanted to discuss. Platelet versus prostaglandin in tissues. While aspirin's effect on platelets lasts 7 to 10 days, most other tissues like stomach lining, kidney, joints can regenerate COX enzyme within hours to days. So taking aspirin every 7 to 10 days does not provide continuous anti-inflammatory pain protocol, and that is because of the lack of nucleus in platelets. Dose matters. 325 milligram tablet makes it 650 milligram. That is a full analgesic dose, not a low dose cardioprotective dose. At that level, risks include gastric irritation, ulceration, GI bleeding, kidney stress, increased blood bleeding tendency, even if taken intermittently. Aspirin for pain versus cardiovascular use. Aspirin's long-lasting efficacy is primarily relevant to platelet inhibition, not sustained joint or musculoskeletal pain relief. So for chronic pain, intermittent high-dose aspirin every 7 to 10 days typically does not provide a steady pain control. Acetaminophen, which is Tylenol versus in between doses of aspirin. Acetaminophen is reasonable for short-term pain control, but it does not reduce inflammation. Liver safety depends on total daily dose. More than 2 grams is not advised. It should be adjusted in liver disease and alcohol use. The bottom line is, from a pharmacology standpoint, the concept is interesting. From a clinical standpoint, this strategy does not reliably provide consistent anti-inflammatory pain control and still carries bleeding risks. Pain management should be individualized based on cardiovascular risk, GI risk, kidney function, liver health, and other medication. If someone needs frequent pain control, there may be safer, structured options. So, let's see. Chuck asked me again a follow-up question, and that question is this one. Chuck is very smart. So he says, platelets lack, he says this. He says, of course, the distinction is that platelets have no nucleus and cannot therefore make more COX. Cells with nuclei can generate more within hours. Yes, Chuck is absolutely right. Platelets lack a nucleus, so one aspirin irreversibly acetylates COX-1, that platelet functionally altered for its entire lifespan, that is 7 to 10 days. Nucleated cells like endothelial cells, gastric mucosa, renal cells, they can generate new COX enzyme within hours to days. That is why the platelets effect lasts longer than the systemic anti-inflammatory effect. But here is the more clinical nuance. Taking 2 aspirin, 650 milligram every 7 to 10 days, even low dose aspirin 81 milligram already achieves near maximal platelet COX-1 inhibition. So 650 milligram dose does not meaningfully increase the antiplatelet effect. It mainly increases systemic exposure. GI bleeding risk is higher with high dose like this. There's increased risk of gastric irritation, ulcer formation, increased GI bleeding, and that may increase hemorrhage, stroke risk. And importantly, even intermittent high dosing can irritate gastric mucosa. Cardiovascular prevention context, modern guidelines have shifted completely. Primary prevention, no prior heart attack or a stroke. Aspirin is used for far less frequently due to bleeding risk. Secondary prevention, if there's history of heart attack, stroke, stent placement, low dose aspirin remains standard treatment. So intermittent high dose aspirin is not recommended commonly for any prevention. So mechanistic trap, sometimes a strategy makes sense biochemically but does not translate into a better clinical outcome. Aspirin pharmacology is elegant, but outcomes are driven by risk benefit analysis, bleeding risk, age, cardiovascular risk, GI history, concomitant medication. The bottom line is yes, your understanding of COX acetylation and platelet biology is fantastic. But clinically using 650 milligram of aspirin every 7 to 10 days is unlikely to offer superior protection and may increase GI risk compared to a standard low dose regimen when indicated. So if someone is considering aspirin for prevention, it should always be individualized. Excellent mechanistic thinking, Chuck. And I thank you for asking such a smart questions.